Wow, this chapter 11 on physical disabilities and other health impairments and ADHD is very vast. Interesting range, too, of physical disabilities being very severe disabilities, other to ADHD, which is considered a very mild disability, a high incidence mild disability. So it's very interesting this author put them all in the same chapter. I try to do justice to it. I am asking you to help out with about 14 different spots. We'll do some of this in class also, where we'll study some of these specific disabilities a little more. But best to you. Hope it's enlightening as far as what some of these needs are. Chapter 11, Physical Disabilities, Health Impairments, and ADHD. All pretty big. I just try to stick some images in here at the beginning to kind of set the tone to show the abilities. And somebody here in a wheelchair, as you can see. And then you see this. Look, what a beautiful little girl with a walker, obviously struggling with some health impairments. And this is just what it looks like. And some very successful teachers, and some of you may become teachers working with kids with severe disabilities. And this is just a look at what it looks like. All right. Is she gorgeous? Somebody working, that's what technology looks like, can really be gainfully employed with the right skills. Here's somebody that looks like he has some kind of an entrepreneurial thing going. Very interesting. Again, you can tell how spastic his limbs are, that he has some disability. So what about it? Well, they're varied, describing a single set of characteristics, impossible, mild, moderate, or severe, and that's how this vacillates the whole time. And I talked about that from the beginning of the term, from one end of the room to the other. From very, very mild disabilities, we're on the other end now, the very severe disabilities. And even in these severe disabilities, you can have mild, moderate, and severe of those. Can be limited in their activities and functioning, may be paranormal, or have highly visible features, highly visible disabilities. May have a single impairment or multiple, have had it since birth or acquired it, may have assistance, may display behaviors that cannot control, may need hospitalization from time to time. This is the group that's hospitalized the most. Yes, and need medicine continually. So first of all, let me flip the textbook and take you a little look through there. Here is the questions, and please look these over. It asks some questions that you're going to want to know for the test. What does the classroom teacher need to know about physical disabilities? And that's you, of course, that classroom teacher. And so of the many ways in physical environment, social environment, and instructional can be modified to support the inclusion of students and health impaired. So that'll be you. And here again is the featured teacher and her insight into this field. So children with physical disabilities and health impairments are extremely varied in population. Again, they may be moderate or severe. Can have single impairments, so kind of what I told you at the beginning there. For example, give some example. Nadine has undergone long periods of hospitalization, finds it difficult to keep up with academic work. Gary takes medication, causes seizures. Janelia tires easily and attends school for only 3 hours. So you can see that variation. So what are these definitions? And again, this chapter is so big and its range that's a little hard to narrow it down. And so what I'm going to ask you to do, this will be our number one here, is a definition for 1, 2, 3, 4, 5 things. Okay. Let's do this one too. A congenital or an acquired. Let's say 1, 2, 3, 4, 5, 6, 7 things for here. You come up with, and that can come right out of here. An orthopedic impairment, a neuromotor impairment. Orthopedic is skeletal, bones, joints, limbs, associated muscles. And neuromotor impairment involves that nervous system. How to move, feel, control. And that's where we'll start this discussion, is based on those two things, orthopedic or neuromotor, and move down here to this other health impaired. Okay. Due to chronic or acute health problems, adversely affects academic performance. And this has been the face of all of these as we study these, because they can have these problems, and if it doesn't affect their academic performance, they'll be eligible for some other support in school, but not special education. Remember, every disability we've looked at, this has been the cornerstone. It has to affect those. So yes, you could have somebody in the school, maybe in your classroom, that is afflicted with one of these disabilities we're going to talk about, that does not qualify for special education. There is other support, but it may not be this one. If it's just an environmental thing, they'll be eligible for other things. So this is the other health impaired. Means having limited strength, vitality, alertness, including heightened alertness to environmental stimuli, which is, of course, is the ADD kids. And the kids with this hypertension disorder may be served under other health impairment categories, with the reasoning that their condition results in heightened alertness, adversely affects their educational performance. However, many children who meet this requirement for ADHD are served under other disability categories, most often emotionally disturbed or learning disabilities. So we have this crossover again that's really hard to get a sound count because of that crossover, the comorbidity of different things. It has to adversely affect the child's educational performance. The child is entitled to SPED service if her performance is adversely affected by the physical or health-related, may be congenital, okay, like chronic conditions or acute conditions. Again, that's comes back here of these. All right. So what's the prevalence of these disabilities? This range says, depending how you count them again, seems really quite a range. Childhood range from 0.22 to 44%, depending on the researcher's concepts and definitions. Middle of that range, somebody counts at about 20% of school-age children. The actual number of research widely accept that the incidence of chronic health conditions increased considerably in recent decades, and that's what I think is alarming. And I've said to you this before, I'm surprised nobody is alarmed and sounding the alarm with this. Is it we count them better? I don't know. You don't. If you're in a classroom in schools at all, you don't have to be real aware to know that there's an increasing incidence of some kind of a disability, even if it is ADHD or autism. And this, they're making a case here, even these more severe. Now, if we go back to 1960, of course, there wasn't it was pre 94-142, so a lot of the kids with these disabilities were not in the school, but that law now from 75 is almost 40 years old, and so that's no longer the case. So clearly their lives are affected by this. They're in our families. Down here, two factors make the actual number of children with physical disabilities and health conditions higher. Number of children receiving services. First, numerous children have chronic health conditions or physical impairments that do not adversely affect. So they're in your school, but they're not counting the special ed roles. And second, because of physical and health impairments often occur in combination with other disabilities, children may be counted under other categories, such as multiple disabilities, speech impairment, intellectual disabilities. For example, for the purpose of special ed, eligibility diagnosis of intellectual disabilities often takes precedence over this physical thing. So you could have a child that's severely disabled that's counted under intellectual disabilities, formerly known as mental retardation, and not counted in this one here. Okay. So what are severe orthopedic types and causes? Literally hundreds of physical impairments and health can affect their performance. Let me just go back here. Club foot, absence of a limb, impairments caused by disease, polymyelitis, bone. Let's make this number 2, and you make a brief description of these. 1, 2, let me get this out. 1, 2, 3, 4, 5 things. Okay, and then just very briefly, 6, 7 things here. That was your number 2. Okay, let me see what this is. Other health impaired, asthma, attention deficit, diabetes, heart condition. And we're going to, in our project, we're going to do some of this, so we're going to leave that for now. So first of all, cerebral palsy. Here was the thing on prevalence. Have produced huge, diverse findings. These are the numbers. I think this is what's on the test, that like 11.6 receiving special services are otherwise other health impaired. Right. Orthopedically impaired, other health impaired. 2 factors. The children's disability health higher than this. Receive services under others, and they have specialized to acquire these services because they're not adversely affected. So, how about this one? This is a big one. It's a permanent condition, so know that about cerebral palsy. It's a permanent condition, and it's a lesion to the brain or abnormal brain growth. This is the most prevalent of school-age children of these. Okay, I would like this to be number 3, that you put this here, this lesion to the brain abnormally or abnormality of brain growth. Put that there, please. Okay, no clear relationship between the degree of motor impairment and degree of intellectual impairment. So that's what's hard, is because they're not lined up right. So you can have somebody severely disabled that has a normal intelligence, or somebody very looks normal, slight, and have more intellectual impairment. Tough. So you're classified according to these things, and this is going to be our number 4. Is a quick definition of each of these: spastic, athetosis, ataxia, rigidity, and tremor, and mixed. 1, 2, 3, 4, 5, 6 of them here. So that's your number 4. Stop and do that. 6 of these. This is number 4. This was number 3. Okay. And let's take a look at this. Cerebral palsy have little or no control over their arms, legs, or speech, depending on the type and degree of impairment. Many cases, cerebral palsy is not detected until 2 or 3 years old. And I've heard these stories. Parents notice their child is having difficulty balancing or standing, and we have assessments that we can compare to what normal is at that age. The motor dysfunction usually does not get progressively worse as a child ages. Cerebral palsy can be treated but not cured. It's not a disease, not fatal, not contagious, and in a great majority of cases, not inherited. Okay, so here too, between 23 and 44 have cognitive impairments ranging from mild to severe intellectual disabilities, and there lies a whole other set of challenges. Sensory impairments are common. 5 to 15% have hearing loss. 60 to 70% have impaired vision. No clear relationship exists between the degree of motor impairment and, again, the degree of intellectual impairment in children with cerebral palsy. Child with mild or poor impairment experience severe development delays, whereas a student with severe may be intellectually gifted, and there's documented cases, even movies made about that. Causes are varied, not clearly known. Might be something that's prenatal, something perinatal, something postnatal. Prenatal being before, perinatal is at birth, or postnatal soon after birth. The result of this, like decreased oxygen, is one that's common, or a low birth weight. However, that have changed the incidence of cerebral palsy, which has remained about 2 per 1,000 live births. And you know, in that case, that's how everything's counted, is how many per live birth. Associated with cerebral palsy are intellectual disabilities and of the motor, intellectual disabilities of the mother, premature birth, low birth weight, and delay of 5 minutes or more before the baby's first cry. Yeah. My babies were both C-section babies, but still, when you first I watched them both be pulled out of their mommy's tummy, and I tell you, you hold your breath for that first cry. And especially my first baby was almost 10 pounds, so they're very worried about him. But he had a little cry, not too soon after I saw him. Because the location and extent of brain damage is also variable in individuals with brain cerebral palsy. Things like this. And here, this will be our number. This will be our number 5. A definition of each of these. Okay. It starts down here. These are just where are those disabilities. Like monoplegia is only one limb, hemiplegia 2, triplegia 3 limbs are affected, and this is how we communicate and talk about this. Paraplegia only legs, diplegia is impairment primarily involved the legs, less severe, and then double hemiplegia is this. So here's the one we talk about. Paraplegia is only the legs, but if your whole body, all 4, then you're a quadriplegic. And that's where this terminology comes from. Okay, so here's where you get the thing about hypertonia, spastic cerebral palsy. That all comes right here, that you'll bring in here, right here, number 5 for each of those. Irregular twisting movements or ataxias or involvement in palsy. Have a poor sense of balance and hand use. Rigidity and tremors. Rigidity are stiff. Tremors, they can't control it. It wiggles on them. Here's the mixed. Here's hypertonia. There's weak thing. Then we have hypotonia or weak floppy muscles. Where was the other one? Yeah, hypertonia. Are tense, contracted muscles. Hyper is too tight. Hypo is too floppy. Both causing problems orthopedically for them. Okay. Then we go to spina bifida. Is a neural tube defects, most common in affected spinal bifida. Result a condition in which vertebrae do not enclose in the spinal cord. Yeah. As a result, the portion of the spinal cord and the nerves that control muscles and feeling in the lower part of the body fail to develop normally because that break in that connection. Most myelin spina bifida occulta. I should have put that in there. Let me grab that one and get that in there for you also because of these types. There you go. I hit this. It comes back. Spina bifida occulta. Okay, so this is where you'll do to. This would be number 6. A little description of each of these: spina bifida occulta, meninsolia, myelocele. And then this one too, what is clean intermittent catheterization, and that is comes here also. But here are those here, and I'm going to put this one in too. This hydrocephalus is an important one, and so. Right here. There. And now you have that one also. Hydrocephalus is interesting too, accumulation of fluid and tissue surrounding the brain. Okay, so that you may need a shunt. And the shunt, I have that here for you. It says here that you result treated with a shunt, and a shunt is just this cord like this. It's just a tube that's inserted in the body to drain that fluid to get past where this damage is. Even you and I could possibly need this if there's some blockage in this drainage, because there's constantly fluid around the brain that needs to be drained away down and passed out of the body. So this is what a shunt is. Okay. Then this catheter, most people too that have this need some form to control their bladder and stuff. So this is the catheter is a bag to collect the urine and clean. Teach the clean intermittent catheterization to children with urinary complications. That some can do it themselves depending on their need. Then MD, muscular dystrophy, progressive weakening and degeneration of muscles. No known treatment exists to stop or reverse any form of muscular dystrophy. Duchenne, and this will be, again, I think this is number 7. You tell me what this is. Marked progressive atrophy, meaning getting stiff. I think that's what I had on here. I'm going to bring that one in here also. And add that here. Okay. Here's this one, most common type. They all fall easily. This is their thing. They're real rigid. Small muscles of the hands and fingers are usually the last to go. The big muscles are first. The legs, they can't walk. They get so they can't walk by age 10 to 14, and that's why I had them in middle school. One boy in particular, I remember, came in 6th grade walking pretty well, and by 8th grade he had to be in a wheelchair because he was falling so much and really starting to hurt himself. And he wasn't real accepting of it, of course. And treatment focused on maintaining function of this, of the unaffected muscles for as long as possible, facilitating ambulation, meaning walking, and the family cope with limitations imposed by the disease, which of course includes some emotional support and counseling. And that's why one of the related services in special education is counseling in situations like this. Physical therapy and exercise, appropriate aids, appliances, stuff like that. No known treatment to stop the reverse of this, or reverse it even. It's been around for a long time. Death is often caused by heart failure or respiratory failure of the chest muscles as they lose that control. And spinal cord injuries, let me have with it there, caused by penetrating injury, fracture, stretching, or compression of the spinal cord. Car accidents, sport injuries, violence most common. Also the paralysis below affected the vertebrae. So wherever the break is, from there down, it's affected. This is interesting. 80% of the spinal cord injuries, and there's again, this is number 8. These two here, 1, 2. Okay, let me go back here. So motor vehicles is the most common. So that's what it means here. Car accidents are the most common cause. These are the top 3, but the most common is car accidents here by quite a ways. 41, falls 27, violence 15, sports 7. Okay. Described by letters and numbers indicating the site of the damage. And if you know anybody's ever had this, this is how you cite it by. So like C5, 6 injury means the damage occurred at the level of the 5th and sixth vertebrae, flexible area of the neck susceptible to injury and whiplash. Or diving or trampoline accidents. T12 injury affects the 12th thoracic. L3 in third lumbar, lower back area. So if you've worked with the saw, you know if you get chiropractic adjustments, they're always talking about this also, is where they're adjusting you. And then here's the most common that are quadriplegias or paraplegias. And children with quadriplegia may have severe breathing problems because muscles of the chest, which normally govern respiration, are affected. Most children with spinal cord injuries lack bladder, bowel control, and of course that presents a whole nother level of need in school, because we're talking about catheters or bowel problems is diapering and changing diapers and stuff, and not so bad in little kids. Gets to be a real issue when they get to be big kids. Need to follow a careful plan to maintain personal hygiene for them and for the workers. Avoid infection, skin irritation. Saying spinal cord injury involve physical therapy, use of adaptive devices for mobility, independent living, maybe personal care attendants involved with it. Okay. This is interesting too. Adults are often particularly concerned about sexual function with these injuries, which is a concern. Sometimes it can be normal, sometimes not. So that's spinal cords. And then seizure disorders, epilepsy. First of all, number 9, tell me, what is a seizure? It's in the book here. Caused by abnormal electrical discharge of the brain. Estimated that 3% of the population is prone to seizures, which I didn't know. And then 3 different categories based on severity, 1, 2, 3. And I want you to do all this. That'll be our number 10. Give me a little definition for all 5 of these things here, how they fit. Seizures can be controlled by medicine, which is good. Here's epilepsy. 3% are prone to this. Approximately 30% cases identified among 50 different conditions as a result of seizure activity. So we really don't know what that is. Infections of the brain, central nervous system, metabolic disorders such as hypoglycemia, genetics, alcohol lead to poisoning, underlying lesions caused by scar tissue, lots of different things. Many misconceptions about epilepsy have circulated in the past. Some remain prevalent today. Negative public attitudes, in fact, have been more harmful to people with epilepsy. Electronic brain. Okay, so there's the generalized tonic seizure. Do I have these? Yes, that's where you get these. Tonic-clonic seizures. Here's the absent seizure. And then you'll bring those in, what they are. And then the complex partial seizure, then the simple partial seizure. Those are the 4 things there. Here's that aura, is the warning sensation before the seizure. You can have, although a student with seizure disorders may be uncomfortable about letting friends know about their condition, classmates should be aware that they will know how to respond and not to respond. And that's a big thing in school, what to do if they have them. Then diabetes is our next one, other health impaired chronic disorder of metabolism. 8.3% of the population, but the body's unable to retain adequate energy from their food. 4 things here. Again, this is BR number 11. These 4 things you define 1, 2, 3, 4. Obviously treated with insulin, diet, and exercise. What are those things? Here's type 1. The onset of hormone normally produced by pancreas necessary for the metabolism of glucose, which the patient must receive daily injections, and that's what of insulin. And that's what that one is. Type 2 is most common form. It's also insulin resistance, the body failing to use insulin. Insulin deficiency occurs most often in adults who are overweight. Now kids too, of course, but recent childhood obesity has led to a dramatic increase of type 2 diabetes in children, and that's well documented. Teachers who have childhood diabetes in their classroom should learn to recognize the symptoms of both too little sugar and too much sugar in the bloodstream. Different symptoms. And here's hypoglycemia, instant reaction to our diabetic shock, and hyperglycemia, too high of blood sugar, and it's the most serious, indicates too little insulin. Too much sugar, too little insulin. This one is too much insulin, too little sugar. Symptoms of this are diabetic coma include fatigue, thirst, dry skin, contact if these exist. So if there's too little, coma include fatigue. Okay, so there's too little blood sugar, you need the insulin here, and if there's too little blood sugar here, giving a child a form of concentrated sugar like a candy bar, cube, fruit juice, or something like that is what you do if their blood sugar is too low. That's be the extent of you as the teacher. Then we'll look at asthma, chronic lung disease resulting in narrowing of airways. This is the most common lung disease in children. Estimates prevalence range from 7 to 10% of school-age children. Interesting. It's a leading cause of absenteeism in school. Causes are unknown, but considered the interaction of heredity and environment together. Okay. Very interesting. The leading cause of absenteeism in school. Controlled effectively by most children with a combination of medications and limiting exposure to known allergens. Most children whose breathing attacks are induced by physical exercise can still enjoy that activity. Chemical of this. One of the things it does not mention here, any place I saw, is the use of the inhaler. That's the most common one that I know of. And we all know those kids that carry those inhalers around, especially if they're playing ball or something. But it accounts for more hospitalization than any other childhood disease and leading cause of absenteeism in school. 14 million school days because of asthma are lost. And so that chronic absenteeism makes it difficult for them to maintain performance. Majority of children with this receive medical and psychological support. And this is the one, too, that really can be quite absent and may not affect their educational things, so they're not on an IEP. And cystic fibrosis, this is the digestive one. Pulmonary and digestive systems, no reliable cure. Getting children to consume enough calories is critical to their health and development because they don't absorb, especially fats. So you're constantly working on that. You need help from teachers and aides and classmates because of this. Although life expectancy of people with cystic fibrosis used to be very short, in the 50s it was hardly made it out of school age. It's much better now. Okay. Can have frequent and large bowel movements because of that lack of absorption. I say consuming enough calories is the most. They need this. Isn't this the one too where they need to have the treatment for it? They undergo here daily physiotherapy, in which the chest is vigorously thumped and vibrated to dislodge mucus. And I know there was a school that had somebody that needed to have this done every day, this therapy during the day, followed by positionings of the body to drain this loosened secretions out. So you're full of mucus and this gets it loose. Very interesting how that's connected to digestion. Okay, and then HIV and AIDS, breakdown in the immune system, prevents the body from fighting infections. There's some universal precautions, no known cure for this. And you don't hear this quite so much anymore. I hear it distinguish the difference between HIV and AIDS, and one is one leads to the other. AIDS cannot resist and fight off infections, and that's the thing. Opportunistic infections such as tuberculosis, pneumonias, and cancerous skin lesions attack the person's body, grow in severity, and ultimately result in death. Is found in the body fluids. Okay, that's the whole thing. It's found in the body fluids of an infected person. Blood, semen, vaginal secretions, and breast milk is transmitted from one person to another by that sexual contact and blood to blood. Also, intravenous drug use with shared needles, transfusions, and screened blood or something like that. Obviously, pregnant women can pass it on to born children. Most people who become infected with this show no symptoms of AIDS for 8 to 12 years, which is very interesting. Not all people who are infected with this develop the AIDS. Also interesting. So you could be carrying it for years and not show anything. And this is very interesting because of the great fear generated by this misconceptions about the spread of the disease. Some school districts have barred children with HIV/AIDS from attending in defiance of the zero reject principle. Isn't that interesting? However, saliva, nasal secretions, sweat, tears, urine, and vomit do not transmit this. And I'm not so up on handling these things anyway, but they're saying it does not unless those fluids contain blood in them. Then it's different. Child with HIV/AIDS in the classroom presents no undue health risks to other children. Interesting. Children with HIV cannot legally be excluded from attending school unless, and this is the big thing. This is what's interesting. Unless they can be excluded, they are deemed to a direct health risk to other children. Okay, like exhibiting biting behavior or open lesions, sores. Interesting because of zero reject, but you can bar these. Of course, you'd provide something else for them. Parents are not required to inform the school that their child has HIV or any other medical condition. Did you know that? All teachers and school personnel should be trained in universal precautions, a set of standards, safety techniques that interrupt the chain of infection spread potential biohazards such as blood and body fluids. So you don't have to tell. Now let's go to this monster, the ADHD. Essentially, the feature is the persistent pattern of inattention and or hyperactivity, impulsivity that is more frequent than severe that is typically observed. So I'm glad we at least acknowledge that some of this is normal. Okay, so here are the subtypes, and this will be our number 12 here, where you define these 1, 2, 3 subtypes. Most ADHD have the combined type. Diagnosis rests on information obtained from parents and teachers, and that's all. That is all that goes with this. Okay. Early on, it said way back in 2002, Still, Dr. George Still came up with Still's disease, and where they were restless and exhibited problems. Okay, that went on to that, had some growth, but then kind of re-showed itself here lately. Persistent pattern of inattention. Here's your 3 things: inattention, hyperactivity, and impulsivity. In 2 or more environments, must occur in 2 or more environments. So that's very interesting. That's all it's done. It's very subjective. It has to interfere or reduce the quality of individuals' functioning in social, academic, or occupational tasks, and not to be the result of another medical disorder. So you have to eliminate some, like mood disorder, anxiety disorder, something like that. Depending on the constellation of symptoms presented by the child, 1 of 4 subtypes are assigned. Combined presentation, predominantly inattentive things. And here it gives you the combined 55% of that, 27% with inattentive type, and 18% hyperactivity, impulsive type. Okay, but the biggest one, like they said, is the combined one. So I say it's highly subjective because it has to do with your ability to deal with it. For example, what is the basis of deciding whether a child is often on the go? And how often does it determine that a child who avoids or dislikes schoolwork or homework does so because of this? A child who is regarded by one physician as not having this may well be diagnosed by another of having this disease. No valid independent tests exist. Diagnosis rests with information from parents and teachers. That's what makes it so subjective. One study found that teachers were the most likely to be the first to suggest the diagnosis. Voila, followed by parents. Parents have been known to engage in physician shopping, taking their child from doctor to doctor until one diagnosed it. So I'm sorry to say that, but we worked with families that wanted that diagnosis. Most frequently cited estimate of the prevalence of this is 3 to 7%. Seems low of school-age children. As approximately 5.4 million children or 9.5%, had at some point been diagnosed with ADHD. And boys, of course, are 3 times more likely than girls to be diagnosed. And it's higher at younger age. The typical classroom will have 1 or 2 children in each classroom that have this diagnosis. Child count data reported by the states reveal a large increase in the numbers of students served with other health impairments category because the federal government has stipulated that students with ADHD were eligible for SPED under this category. Some states reported an increase of 20% in this number between 77 and 97, 98, 99 school years. The number of children served in other health impaired categories increased dramatically during that time. And they have the same thing that sometimes 58% of the students receiving SPED services under the disability category of emotional disturbance have these also. 30% repeat 1 or more grades. So that's the other thing, is it could be under some other category. 58% of kids with this get it under emotional disturbance are considered emotionally disturbed. And had ADHD, with 20% of those students receiving SPED services under intellectual disabilities and learning disabilities. So again, it's hard to get a count because they can really be spread out into these other categories. And what makes them eligible? 40 to 50% of students with ADHD qualify for SPED services. Majority being served under disability categories of emotional disturbance and learning disability. Many children do not served ID are receiving services under Section 504, which is a civil rights law. We'll talk about that in Chapter 1 a little bit. Under schools may be required to develop and implement accommodations plans to help students with this. A lot of complaints about that it hasn't been real successful. Accommodation plans often include such adaptations and adjustment extended time, preferred seating, additional teacher monitoring, reduced or modified class or homework assignments and worksheets, things like that. So what are the causes? No clear, consistent, causal evidence links brain damage or dysfunction. They're just not well understood. Similar patterns of behavior leading to the 2 different children likely, not certainly, will be caused by different things. Can be associated with a wide range of genetic disorders. Have structural or biochemical differences in their brain. Have brains that appear different. Not all with this. Their brains that appear different. So it's really kind of a wide open thing. Treatment, drug therapy, most widely used treatment for the children with this. 3 to 7%. Common, no clear evidence indicates that stimulant medications lead to improved academic performance. Okay, then it takes you through some of here. First of all, Ritalin, which is the most common one, is most frequently prescribed. Other stimulants, dextrin, another one, Adderall, I've heard of, Disoxin. All these are medications for this. Increased tremendously since the 80s with 7 children. Has proven to be safe and often effective intervention. Reviews of controlled studies show 70 to 80% of school-age children diagnosed with this respond positively to Ritalin, at least in the short term. Show either no response or negative response. So you have that too possibility. No response or negative response to it. Includes a reduction in hyperactivity, increased attention and time on task. Although teachers and parents generally report favorable outcomes of children who are taking the medication. Common side effects include, this is what we don't like, insomnia, a decrease in appetite, and when I was working with these kids, I saw this all: headaches, weight loss, decrease in positive affect, and irritability. And this is why some don't want their children on them. The short duration can be controlled with a reduction in the dosage. Goldstein believe that the immediate short-term benefits of it far outweigh the liabilities, and thus appear to justify this. Otherwise, it could be considered malpractice not to include. That's interesting. Think of that term. That they're suggesting that if you don't do this, it could be construed as malpractice. So if you don't want your child on it, it'd be considered a malpractice. No clear evidence indicates that stimulation medications lead to improved academic achievement. Well, that kind of backfires a little bit then. A longitudinal study that followed children with ADHD who had taken Ritalin for 4 years found that children did not make gains in either specific or general areas of academic achievement from the 1st through the 5th grade. Wow. So why would we do it then? And they documented here that this was Frankenberg and Cannon in 1999. Interesting. So that kind of flies in the face of this, of its malpractice not to do it if we don't see the gains. Prescription of stimulants, it's important that teachers have valid knowledge of the conditions of its treatment. I remember when I was in middle school, we had one kid selling them, and the kids were breaking them up and crushing them and putting them up their nose and getting a buzz from them. And the kid was collecting $1 a piece. And how they caught him was at the end of the month, he ran out before he should have, and the mom said they should be there, and then they found out here he was peddling them. Fortunately, educators hold many misconceptions about ADHD and its treatment of stimulant medication. These people asked 145 teachers to rate how much they agreed or disagreed with these statements, and then they did that and came up with this. Okay, so they're saying they didn't know much about it. So behavioral interventions, we go back here. That does include positive reinforcement. We talked about that on other chapters. Modifying assignments, structural activities, promote success. A deficit of execute functioning is a primary characteristics of this. So you're trying to teach that. You're trying to modify their environment. Here's the executive index. Or the ability to verbally think through and control one's action. That's what executive function is. Okay. Then characteristics of all the kids with learning disabilities. That's kind of the end of that. Group students with physical disabilities or health impairments function well below grade level, and that's not profound. Daily health care routines and medications can have negative side effects. Progress is often hampered by frequent, sometimes prolonged absences from school. As a group, students with physical disabilities and health impairments perform below average on measures of not only academic but social behavioral skills. Concerns about physical disabilities are frequently identified as reasons for emotional difficulties, and this one, depression. Then factors that affect their educational needs is severity and then the age of onset, because it's kind of like we talked about in vision and hearing is what could you do before the onset of this? Acquired impairments have different needs, and then visibility is also a big thing for kids. What does it look like? Visibility impairment may cause some to underestimate the child's abilities or limit their opportunities. And that's what here. Treatment of cancer may prolong and enhance life. Child lead to complete remission of the disease or have little or no positive effects. Then two things, many children with physical or health impairments well above grade level. Social interventions, and then variables affecting this. Disabilities or health impairments may need intensive instruction in a parallel curriculum to include using adaptive methods and increasing independence by self-administering special ed care routines is one thing they can do. That's the visibility. to educational approaches. And this teaming approach here, and this will be, I can't remember where we're at, this will be our number 13 here. A definition of each of why these need to be in here, this teaming approach on it, and it's all laid out here for you. Here it tells what the role of each of these are here and why they play a role in this. You ever heard of this? An orthoist who design and fit braces and other assistive devices. But this is all the people, and if you ever go to an IEP meeting, I used to go to IEP meetings for kids at Children's Care Hospital and school, all of these people would be involved. Of course, their clientele are all so much more severely disabled. And what kind of environmental modifications can the school make? And this is interesting here. Assistive technology. Defines assistive technology as assistance technology devices and the services needs to help a child obtain and effectively use devices, piece of equipment, or product used to increase, maintain, or improve functional capabilities. This may directly assist with the selection, acquisition, or use of technology. Then there's animal assistance. Can be like from dogs or monkeys are the latest ones, and the specialized healthcare routines. Special health, importance of positioning, seating, encourages development of muscles and bones, lifting and transferring. That's all back here. This was the assistive tech. IEP team should carefully consider certain characteristics of the child and the potential technologies that might be selected, as well as the impact of using those technologies on the families. Assessment of the child's academic skills and social skills and physical capabilities should help identify the goals and objectives of the technologies, narrow down these kinds. Here's the animal assistants like monkey helpers. They can also have social value to the person. Healthcare needs and specialized prescribed medication or self-administering insulin shots can be part of it. That's an individualized healthcare plan. It's what they need to be successful that way. And this is interesting about positioning and seating. Good positioning results in alignment and proximal support of the body, stability and positive effect use of the upper body. Stability promotes feelings of physical insecurity and safety. Good positioning distributes pressure evenly across the comfort for seating tolerance and long-term use. Can reduce deformity, and positions must be changed frequently. Proper seating helps combat poor circulation, muscle tightness, pressure sores, and constitutes proper digestion, respiration, breathing, and physical development. And now it's a huge thing with these kids that constantly repositioning them. They should face forward in middle position, shoulders should be midlined, trunk should be midline position. And what I observed in all this too is when they're little it's easy. When they get to be high school and adult age, it's much, much harder to reposition them. Okay. This here was on lifting and transferring students. Make contact with the child, communicate what is going to happen, prepare the child physically for the transfer, and require the child to participate in the routine as much as possible. Kind of like we said with the dog, you don't touch them until you've talked to them. Out of respect, independence, and self-esteem, what they need for that. Then educational alternative placements. Children need encouragement to develop a positive, realistic view of themselves and their physical conditions, as much independence as possible, the ability to explain their physical disability or health conditions to others, collaboration with self-help groups on this. No other group of exceptional learners is the continuum of education placement services and options more relevant. Let me, where was this one at? Let's say this will be number 14, and this will be our last one. You tell me what is the continuum of educational services. You list those from most restrictive, from least restrictive to most restrictive right here. That's 14. During the 08-09 school year, 52% of students who received SPED services under the category of orthopedic impairments were educated in the general classroom. Who is the biggest group of other health impaired? ADD, ADHD. And that's why, for the most part, they're in the classroom. 17% resource rooms and 24% in a separate classroom. 60% of students with health impairments were educated in general classrooms. 24% resource rooms. Technology-dependent students need both a medical device and ongoing nursing care to avoid further disability. So they're called technology-dependent students. And these related services, controversial issues concerning including students with physical impairments and health care needs in general classrooms. The extent of responsibility properly assumed by teachers and schools. We studied this case. Irving versus Tatro and Cedar Rapids versus Garrett. This was catheterization is a related service and nursing services are related services. Acceptance is the most basic need of children with physical disabilities. Okay, and that's kind of how this ends, is the placements of them. What is a technology-dependent student who needs both medical and nursing devices? Home hospital is a real thing here. After examining the experiences of 77 families of children who are ventilator assisted, barriers of integration of these children. So they're saying still it's, here's those two cases. And attitude is still, this is interesting, 365 children with chronic or illness are reported that 1/3 of the parents had experienced specific incidences of discrimination concerning their children. Okay. So that's chapter 11, other disabilities.